started, and hopefully the few remaining people will join us as the webinar moves on. So my name is Lydia Franco. I'm part of your CTAC PEDS resource team. I am here today with Julie Gutowski. We're very excited to have her present this first webinar on anxiety as part of the PEDS learning community. She is the Managing Director of Clinical Operations at Spectrum Human Services. She not only manages a number of clinicians doing direct work with both children and adults, but she also sees clients herself and has worked with a significant number of clients around issues of anxiety. So I think we're very excited to have her present the topic to you, as well as incorporate some of her own personal experience, as well as her clinician experience to really bring this concept home and to help process any questions or concerns you may have about starting using the MAP system with one of your clients. So I'm briefly going to review the agenda for today. First, we're going to do a brief overview of getting started with the MAP system to address issues of anxiety with children. We're going to briefly review some of the key concepts that we covered in the last webinar around clinical complexity and crises of the week, otherwise known as COWs. We're going to talk about anxiety diagnoses and what those are. We're going to talk about assessing baseline anxiety levels and continued monitoring of progress. We're going to begin talking about some of those common practice elements that when you do the P-web search come up when you do a search under anxiety. So first, and for today, we're going to primarily focus on psychoeducation or engagement is another way to put it. I really kind of introducing the concept, the different types of treatment elements and what that will look like for both the parent as well as the child in treatment. We're going to talk about the next steps in your participation of the learning community, and we're going to have some time at the end for questions and answers. I also want to point out that you do have a chat box on the right-hand side that you can send a question during the webinar, and just make sure that when you type at the bottom that you click send to all panelists. That way, not just to host, but to all panelists. That way we can all see what your question is, and we either may be able to answer it during the webinar or at the end in that last Q&A section. Periodically, we're also going to check in with you and ask you to answer a poll or to type in a specific response to a question that we may pose. In the meantime, everybody is muted, and please make sure that you're either listening through the phone or through your computer speakers. So just a couple kind of key concepts. We're very excited to get this second quarter started. We are very thankful to all of you for participating in our learning community, getting started with a depression case these last couple of months, really just trying to get a feel for the MAP system, and we so very much appreciate the feedback that you have given to us, both about how useful it has been as well as any feedback around challenges or difficulties in the system. I just want to make it clear that this is really what the process is about. It isn't about whether this is a perfect system to use with your clients, but that really is about your experience with it, how well it works, how well it doesn't work, and we really are looking for all types of feedback, both positive and negative. And we just wanted to thank you for really participating and moving on with this process. I do want to point out that although today we're kicking off working with a client who has anxiety, that doesn't mean that you have to stop using the MAP system with your client who had depression from the last quarter of the learning community. Again, it's up to you and your clinical judgment. If the MAP system is really working well with that client, we welcome you to continue using it. If you decide that you want to try a different approach, you're welcome to do that as well. If you weren't able to get a case started, that's fine as well. You can either try to continue applying the system to a depression case, but what we really hope that you'll be able to do is just start fresh with an anxiety case and just start along with the rest of us. And I know there's a couple clinics or a couple clinicians that are starting a little bit later in the learning community, so you're welcome to also just start with a case of anxiety with the rest of the group. So before we move on to using the MAP system, we wanted to ask a polling question. So what number of children on your caseload is anxiety an important component of their clinical need? So do you have 2 or less cases, 3 to 5, 5 to 8, or 8 or more? And you can just take a moment. The poll popped up on your right-hand side if you can click. In a couple seconds, we're going to see what the results are. And please, it would really be beneficial for us if everybody attempted to respond, or at least just take a guess if you're not 100% sure. Okay, Evelyn, when you find that most people have responded, you can just pull up the results, please. And this is a question that's really going to help us gauge how easy it may be to help you identify a case of anxiety. So the results, everyone's going to be able to see the results. They'll pop up in a second or so. Okay. So here what we find is that we're kind of a little all over the place. Couple have 2 or less, 19% have 3 to 5. A few of you have more than that, and a few of you weren't able to answer. So it sounds like there's going to be a mix of experiences from many of you. Some of you seem to have lots of cases with children with anxiety or some type of anxiety as an important primary component, and others may not. And we will work with you to help you to continue to identify a case. And I think Julie is going to really focus on helping to figure out what are those key symptoms and diagnoses, and what is that criteria to help you identify a case.
Thank you.
So I want to pass this on to Julie, who will get started talking about the MAP system.
Thank you. And I wanted to start out by thanking everybody for participating in the project in today's webinar. This is really interesting stuff that we're doing here that really should help improve our clinical practice. And we're all in the field because we really want to help people. And so the hope is that this is really going to help us help our clients a little bit better or more effectively than in the past. Now, when we started with the depression, some people found it difficult to find a client to use for the MAP project and the PEACE project. And I think what was happening is many people were trying to find the perfect client, and the reality is the perfect client does not present to our clinic. There is no such thing as the perfect client. So what we want you to really look at is you're looking at an individual who comes to your office for your help, who has anxiety and it's negatively impacting their life. So if you're looking for just a straight anxiety case, a lot of times that's not the client who walks into our offices. A lot of times we have a lot of complex cases with many different things going on. And so that's what we wanted you to think about. Just choose a case that you're just starting, that the person has anxiety and it's negatively impacting them. Now, as Lydia said, I not only supervise clinicians, in addition to training and being part of the CTAC team, we have 13 outpatient clinics in Western New York, and we have 6 clinicians who are participating in the project. And so there have been some challenges related to finding the client, and I wanted everybody to understand it seemed to be a pretty consistent problem. Another challenge seemed to be the Excel worksheet, that it seemed to be a little bit challenging to figure out how to set up. And so what we worked together as a team is we figured out and we created the Excel worksheet, and we're going to go through that with you, and you guys will all get that in an email, and it'll also be on the web page. And some challenges that we have in the field include the complexity of cases. Like I said, we typically don't have somebody who comes into your office who has one set of problems or one diagnosis and everything else is great. A lot of times we're really seeing children and adolescents who have many different issues, and may have a lack of resources and supports that can make things challenging. And one of the challenges also is to stay on track and staying focused when you're really looking at the individual. Another challenge can be, where do I begin when somebody comes into my office, and if it's a 13-year-old girl who has anxiety and she's demonstrating self-injurious behaviors and she has suicidal ideation, what do I address first? And what we want you to think about are, what are some ways that you do this as clinicians? How do you figure out, what do I address first? So if you could chat that in the chat box, I'd appreciate it. And again, the chat box is to the right of your screen. So what are some challenges that you've found using math, but also just working in clinic? And I'll give you a minute or so to formulate some answers. And just a disclaimer, we will be speaking briefly about post-traumatic stress disorder during this because it is considered an anxiety disorder, but really we're going to be touching that more in depth the third quarter when we're working on our trauma issues. And we all know that anxiety is highly correlated with PTSD. It's one of the primary symptoms of PTSD. Well, it seems like some of the challenges can be the complexity, like we talked about, of the children who come and who need services, and if some challenges could be parental substance use, parental mental health issues, very limited resources. So thank you. What does clinical complexity mean? Really, we're looking at and we're working with people who have typically numerous problems. Again, caregiver, mental health, substance abuse issues, challenging life conditions such as homelessness, domestic violence, community violence, not feeling safe in the community, financial stressors at home, physical health problems, death in the family, stressors in the family. Clinical complexity really means different things that contribute to what's going on with the individuals we're working with. So, deciding where to begin. This is really primary when we're working with people, and we kind of wanted to talk about, deciding where to begin is thinking about treatment as a continuum, that it is an episode, it is not ongoing. And so when somebody comes in, there's like the beginning stages of treatment, then we have the middle stages of treatment, and then when somebody's getting ready to successfully complete, we have the end. And so as part of the MAP system, there is the treatment planner, and we're going to talk about that in a little bit, and that can help you to decide. And thank you, Sonia. Some of the challenges that she finds people facing are the limited amount of time we have in clinical sessions to work with especially complex cases. If you have high-risk cases related to suicidality, self-injurious behavior, substance use, I can absolutely understand, and I think many of us can relate to that challenge. So where do you decide where to begin? I guess the first thing is safety. We need to make sure our primary purpose is to make sure that the people we're working with are safe. So any major safety concerns, you're going to start addressing those immediately. And then also urgency. The reason you want to start looking at urgency is, for me, it's kind of part of the engagement process. So if a parent brings a child in for therapy because the child continues to miss school and is avoiding school and showing up late, and CPS is going to be involved, one of the things that we should be working on right away is to try to look at how can we address that immediate concern. It engages the parent, it engages the child, because if we can't address the presenting problem or the reason the client, mother is bringing him in, or the parent caregiver, engagement is going to be impossible, and many times we'll lose that client and they'll stop attending. So focus on a problem area in which the family strengths can be utilized is another great way to help you to begin. And I love this. Where are you likely to get an early win? right? So as part of engagement, we want to show that we have a benefit. There's some meaning and purpose to the client coming in to see us. And so you're really looking to get an early win, because we're going to build upon those early wins when we start asking people to do a little bit more in-depth work, such as exposure. And begin where you have information to develop a plan. So realistically, you're going to be looking at anxiety practice elements. This is a treatment planner worksheet. Again, if you think about treatment as a process, when somebody comes in, typically the first 2 or 3 sessions are related to assessment. What we're doing is we're gauging somebody's level of risk, what's going on in terms of symptoms, and what do they want out of treatment. We need to have some engagement throughout that, and the beginning part of treatment really is the engagement, the assessment, psychoeducation, monitoring, and self-monitoring. Those practice elements, or I call them clinical interventions, should happen at the beginning stages of treatment. After we've had those early wins in those practice elements, then we would move on the middle. This is really the working part of treatment, and that's where we're really going to talk about the cognitive pieces of anxiety, teach people relaxation, problem solving, exposure. And then the end is maintenance. We want to make sure that the child or adolescent has the skills he or she needs to continue to have all the benefits they've had from therapy. So the anxiety is manageable, okay? So they're not missing school. So you really want to think about it when you're doing the assessment to gather that information and work with the client and the caregiver to figure out the plan or the map for treatment. Managing cows or crisis of the week. A lot of times this is probably one of the most important clinical skills, because our clients, when they come in, they not only have anxiety, but they also have many other problems that are going on. And a lot of times what will happen is somebody will come into my office and they'll have a crisis of the week. The crisis of the week typically changes from week to week. And so what do you do as a clinician? So what is a cow? They're the crises that arise between sessions that may become the focus of treatment. Why are cows important? Because they can take up a lot of our session time, and the problem is we keep putting out these little fires, but our house is on an unsteady foundation and it's going to collapse in on itself. But the problem is we feel like we need to keep putting out these little fires before we can address to the foundation. And it can become the focus of most, if not all, sessions. And cows can involve situations that are not in the control of the child, the adolescent, the caregiver, or even the practitioner. So it's really important to manage the cows of the week. How do you stay focused and effectively respond to cows? Number one, again, we're looking at safety. You need to assess the urgency of the situation. What I also always try to do is when a cow presents in my office for a session, I try to figure out how I can take the cow and engage the person and make them feel supported and help them develop a plan. But also, I know that I need to keep following the map that we've set out. And how can I take the cow, how can that crisis be used to support one of the treatment plan goals and objectives? So you're going to look for the connection between the presenting issue. Cows may be addressed and acknowledged in a respectful and empathic manner. So you want to understand, and you want the client to understand, that this is really important to him or her, and it is really serious, and we're important, we care how they feel about this immediate situation or crisis. And I think that's really important. And then the other part is to establish the purpose and focus of treatment right from the start. That cows will come up, and when this happens, what we're going to do is we'll spend a few minutes addressing what you're feeling and the crisis of the week. But then what we need to do is really get back to the treatment plan, because if I just put out fires and I never stabilize the foundation of the house, things aren't going to get better. And provide a rationale for the importance of staying focused on the experience. So what you're going to do is you're going to try to take the cow or the crisis of the week and integrate that into the skill or the therapeutic intervention that you were applying that session. How's in coping? So realistically, you have a couple of ways to address crises and a problem-focused coping skill. When the crisis is definable, it may be addressed directly by problem-solving strategies. This is great. So this is a crisis occurs, it's within the client or the client's caregiver ability to solve. So we would do some problem solving with that. Other times what happens is a cow occurs, client comes in, got into an argument with the English teacher, thinks the English teacher doesn't like her, that she's out to get her, is being unfair to her. We know that the client has no ability to change what the teacher does, and so what we would be doing is helping the person understand how they can manage their emotions about the situation. Okay, so those are your two ways of coping. One of them is problem-focused, where the client or the caregiver has the ability to change the outcome. The other is emotion-focused, where the person can't change the outcome, so let's look at and work on how they feel about it and how they're coping with it. Tools that help the practitioner help you guys stay on track. One of them is the treatment planner worksheet. And I think what happens is, if you get yourself used to using these tools, and really they are tools, if you get yourself using these tools as part of your clinical practice, I think they become ingrained and they become just the way you do business. So if you start using the treatment planner worksheet from the first day with the individual when they come in for the assessment and you're explaining the system and the map and why we use MAP, you're going to be better off. It's going to help you stay on track. You can use a practice-wise system, again, right from the assessment. I wouldn't necessarily spend a ton of time on it, but what would happen is I would introduce them to the idea of, hey, I may work a little differently than other therapists you've worked with because I use this system. Can I show it to you real quick? And I just wanted to let you know, does this make sense to you? Using the session planner, that your sessions really have a flow and, again, a smaller map. The first few minutes come in, it's chit-chat, it's engagement, it's support, and then the bulk of the session really is devoted to the practice element or the clinical intervention, working on that IAP treatment plan and the goals that were identified by the client and the therapist during the assessment process. And also using the dashboard and explaining to people why is it important that you want them to measure things such as, in this case, their level of anxiety on a weekly basis, or why you're using a standard measure such as the RCAD. When you start that from the first session, it just becomes part of the way you do business and part of the way that you do therapy, and it normalizes it for the client, and it also helps you stay on track and focused. So what I wanted to talk a little bit about, so that's kind of, I wanted to start with the basic building blocks of treatment as a process. And this quarter is devoted to anxiety. And so what we're asking you to do is to find an individual who has anxiety. Anxiety doesn't necessarily have to be the primary problem or the primary diagnosis, but the individual you're working with needs to have anxiety that's having a negative impact on him or her. And so we have a few anxiety disorders according to the DSM-4-TR, and I am not going to go into each specific disorder. What we have done for you guys, though, and we have these as handouts, and they'll also be available on the website, is we've created a document, and this has the diagnostic criteria for the different anxiety disorders. And so I just wanted to show you that we do have this document for you in case you need it. For me, part of the way that I've always worked in clinic is I always had the luxury of having my own DSM-4-TR, and if you don't have that, that's okay. We've kind of simplified it for you. And so here are the diagnoses. And the anxiety disorders that fall under anxiety disorder is generalized anxiety disorder, GAD, obsessive compulsive disorder, OCD, panic disorder, separation anxiety, simple phobia, and social anxiety disorder. Also under there would be post-traumatic stress disorder. However, what we're going to do is we're going to cover that disorder in far more detail in the next quarter when we're addressing trauma. So the next few slides we're including for you, these are information specific to adolescents and children who have generalized anxiety disorder. So you're going to have the DSM-4 TR diagnostic criteria available, but we're also giving you little information that are specific to children and adolescents. Some common worries include tests, grades to the point of being perfectionistic, natural disasters, being physically attacked, adult concerns that the child or adolescent really doesn't have any control over, such as family finances, health of others, very concerned related to the physical health of the mother or father, regardless of whether there is a true diagnosed health concern of the parent. Okay, onset and symptoms usually begin in middle childhood, 9 to 13, a lot of somatic complaints, headaches, stomach aches, a lot of tension and inability to relax. OCD, normal development rituals, rearranging the toys, nighttime rituals that can differ in content from OCD rituals. So sometimes a ritual can be every night before I go to bed, I have my 9-year-old daughter brush her teeth, and she drinks a glass of water after, and then she goes to bed and I read her a story. Is that a ritual? And what I would say is it might be, but it's not a ritual that would cause any kind of clinical focus. The focuses in OCD really would be what would happen if I ran out of toothpaste, or she needs to have the toothbrush in the same exact spot and the cup needs to be in the same exact spot. A lot of times children who have OCD don't recognize the unreasonable nature of their obsessions or compulsions, okay? 90% of children, symptoms change over time. In school, the behaviors can be repeated checking and erasing in schoolwork. Panic disorder, it can be difficult to diagnose in children. Young children can report a fear of becoming sick or vomiting. Hard for young children to verbalize specific fears of dying, going crazy, and losing control. They just don't have the language skills or the vocabulary that adults do that can really speak to this. Separation anxiety, there's some developmental differences. 5 to 8, fears of harm, nightmares, school refusal. 9 to 12, excessive distress when separating from parent or caregiver. And 13 to 16, somatic complaints and school refusal. Simple phobia, so you're afraid or the person's afraid of one specific thing, or it could be numerous specific things, like afraid of heights, animals, situational, elevators, dentists. Others can be choking, vomiting, loud sounds, clowns. And then normal development, that the fears in phobic reaction are excessive and out of demand of the situation. It can lead to avoidance and it persists over time, and it negatively impacts the person and his or her quality of life. Social phobia, here are some common characteristics, often have few friends, reluctant to join group activities, endures feelings of loneliness. So it sounds like some of these common characteristics also, if we don't address the common characteristics, such as few friends and reluctance to join groups and activities, it'll really continue to impact the person because we learn social skills and interactions and what positive and pro-social interactions are from interacting with others. And so if a child or adolescent doesn't engage in those typical activities and they have social anxiety, what can happen is it kind of just perpetuates because they have less opportunity to change and learn from their peers. Okay, assessing baseline and progress monitoring. There's two ways that you can kind of do this. And the first way is a standardized measure. And what we're suggesting is that you use the RCAD. You can use other measures if you want, absolutely. And then child-specific measures, and we're going to speak to that in a little bit more depth in a few minutes. So why is assessing baseline and monitoring progress important? And so we found this great quote on the internet: practicing psychiatry without rating scales is like practicing family practice without a blood pressure cuff. Now, if you were at our training that Tom and I had given in Syracuse, I gave a personal example about why is it important to measure progress. And I hope you don't mind a little bit of self-disclosure. I love chicken barbecues, and I love to go to them, and I want to go to as many as I can every summer. So last summer what happened is I decided I was going to go to as many chicken barbecues as I could throughout the summer. By the end of the summer, when the chicken barbecue season was over, I had attended exactly 0. I had no plan, and there was no baseline for monitoring progress. So did I succeed at my goal? The answer would be, well, I guess I did, because I said I would attend as many as I wanted, although as many as I wanted, you can't really measure that. So it's important to measure baseline and monitoring progress. It helps the clinician. It helps the client. Let me give you an example. I was working with a girl. She was about 15 years old, suicidality, pretty much all day waking since she was 8 years old. It's her first treatment episode. So suicidal ideation all day, every day, from waking from 8 years old till she went to sleep at night. I had worked with her for about 6 months, and she said, you know what, I really don't feel like I'm getting any better. And so I said, okay, well, let's talk a little bit about that. And because I do use measures, what I said is, well, when you came in, this was your measure, this was your score in terms of how you felt your life was. And now it's 6 months later, your score is better. So let's talk about what would need to happen to increase your score even more. And so it was a nice way for her to recognize that the 6 months worth of hard work really did have an impact, because number one, the amount of time spent related to suicidal ideation on a daily basis decreased in that 6 months. And also, overall looking at it, she felt her life quality had improved. So those are the reasons that you want for a client. You want to acknowledge all of the hard work. For a therapist, why I want to measure baseline and at certain points throughout treatment is, I want to know, is what we're doing effective and helpful for the person. So what we're asking you guys to do is, we have the RCAD, that's the Revised Child Anxiety and Depression Scale. And let me see if I can show you what that looks like real quick. And so this is a brief questionnaire that the parent, and then there's a child version as well, fills out, and they answer never, sometimes, often, or always, and you can score it. So what we're going to do is we're going to be able to give you the RCAD, and we'll also be able to set up an Excel document like I shared with you, and so you can, all you have to do is input the scores for the RCADs in there, okay? It's used for youth age 6 to 18. Again, it has the caregiver and the self-reports. And then there's scoring. What we've done is we're also giving you another resource that will tell you how to score. Let me see if I can find that. Might be this one. Okay, here's your general anxiety subscale. So if you really just want to measure general anxiety, you would ask these questions, and then we give you the rating scales so you know how to score the instrument. So if you're using the full 47-question RCAD, what we've given you here are the anxiety items in the RCADs. It also measures for depression. I just didn't put it on here because the webinar is about anxiety. So if you wanted to specifically assess and measure social phobia, you could look at the related items 4, 7, 8, and the rest of those. And those are pretty clear on the RCADs. Some examples of anxiety questions on the RCADs are, I worry about things. Again, people need to do the Likert scale between 0 and 3. When I have a problem, I get a funny feeling in my stomach. And what we'd like to do now is ask a poll question. And so remember, the polling information will be at your right. And the question is, do you currently use a standardized measure of anxiety to assess baseline, that's when they first walk in the door, and monitor for progress? 1 is all or most of the time, 2 is some of the time, 3 is rarely, and 4 is not at all. So we would ask you to answer that question, and we'll give you guys about another 45 seconds, and then I'll ask for the polls to be closed. And then we'll get our results, and everybody will be able to see them. Okay, and so it looks like not at all was the highest. I'm going to disregard the no answer at 47%. And I'm a cards on the table kind of person. I wonder if we have so many non-answers because the number of panelists we have, like I'm not answering, so I wonder if that skews the results. I'll try to find that answer out. So not at all is 29%, and then our next biggest group is all or most of the time at 12%, so I think that's really great. And then if you could, in the chat box, if you are using measures, if you could let us know what measures you are using to assess and monitor anxiety, that would be great. We just want to get a flavor as to whether anyone is currently using the RCADs or if there are any other screening tools out there that you're recommending and you think does a really nice job of capturing and measuring anxiety. So like we talked about, you have the, okay, so we have the Spence Children's Scale, the RCADs, the CAPS. Perfect. Thanks, guys. I appreciate you putting that information in there for us. So we have a standardized measure, and then we also have the client-specific anxiety indicators, like a self-report of anxiety. Examples can be the worry ruler or weekly monitoring, and then behavioral indicators. And so really behavioral indicators are reduction in avoidance of people, places, or things. So really, are we looking at the person measuring school refusal, number of days attended at school, or number of days that the person didn't attend? Another behavioral indicator that I like to measure is an increase in pro-social behaviors. And another great thing to measure is increase in helpful coping strategies. Instead of using strategies that may not necessarily be helpful, such as substance use or self-injurious behavior, avoidant behavior, what helpful coping strategies or positive coping strategies is the person using, and are those occurring more frequently since the person started in treatment? So what we have here for you guys, and it's going to be available as a standalone document. It'll also be on our website, is this is a level of anxiety, very simple calendar rating. So what you would ask is for the child and or parent to get together and rate at the end of the day what was the average level of anxiety throughout the day. And then what you're going to do is at the end you're going to get a weekly average, and the weekly average is what you would put into the Excel document. And I'm going to try, okay. Bear with me for 1 second because what I need to do is I need to share my desktop, and I haven't done this live before, so. Okay. Hopefully you guys can see my desktop, and what we're doing is we are going to send this to you as an email. It'll also be available on the website. And so what we're going to, it's the same Excel document that you set up for the depression, but what we've done is we have set up, so it's going to measure the RCADS anxiety subscale and also the sum of the anxiety rating week. Okay? And so here goes your date. Okay. I'm sorry, because I am a computer nerd, I put periods instead of the slashes, and the program doesn't like it. So let's put 47 here, and we'll pretend that was the RCAD score. And one of the scores, I think, was a 7.4 for the weekly score. Change this to 9.1. And then now I'm going to change this to 9.10 as if the client came in today. And now I probably wouldn't do the RCADs every session. What I would do is I would do that monthly, so I have a nice set of scores so I can check progress. But what I would do every single session is I would do the anxiety rating, the score for the total. Okay? So that's all you have to do. You put in the date and then you put in the score. Data practices, and I'm just going to walk you guys through this real quick. I hope you don't mind. I'm going to take the dates. And then I'm going to pretend that I did activity selection, and even though I didn't, and I did assertiveness. Okay? So now when I go to the presentation results, you see what my scores are. I only have the one score, which is the blue from the RCADS, because I only took it one time. I only put one number in there. For the weekly anxiety, you'll see that I have the two scores, and it seems to be going down, which is exactly what I want it to do. So what you do is in the data progress, you put the date and the score for the RCADS and the score for the weekly rating scale. And then it'll pop up under your presentation results. So hopefully, and the Excel document is called the dashboard.
So Julie, I just wanted to step in a minute and just clarify that the slide you're seeing right now, the level of anxiety, that is a tracking form that you're going to have available to you. And the idea there is that every day the client or the parent of the client gives them a score of anxiety, and then you just average that at the end of the week. And it's that average, so you saw Julie put in a 7.4 in her dashboard. It's that average that you would put in on a weekly basis when they come in for their sessions. You would put that into the dashboard.
Thank you. I appreciate the explanation for people. And it's a very simple tool to use, and I think it's very effective. And I think it'll be really helpful for both you and the client so they can see the progress. And if there's not progress, you know, look at the treatment plan and decide what changes need to be made. So now we're really going to talk about evidence-based approaches to addressing anxiety in children and adolescents. So we took the liberty, I hope you don't mind, of running a P-Web search for you related to the anxiety results. We didn't do gender, we didn't do age, we did a general sort, and we chose level 1, 2, and 3 studies. And the practice elements that are in green are the ones that had the highest percent, meaning those are the practice elements you should be using for somebody who has anxiety, who's a child or adolescent, okay? And so psychoeducation, caregiver and child came up, as did relaxation, exposure, and cognitive. Now we're going to spend a little bit talking about psychoed, caregiver, and child during this webinar. The next we're going to focus on relaxation and probably cognitive. And exposure will come into a later webinar, and the reason for that, even though exposure is very important to use and really one of the highest cited practice elements you should be using if a kid has anxiety, you need to have the engagement piece, and you have to have the building blocks before you're going to be able to do the exposure to make sure that it goes well and to give it the highest likelihood of success. So again, here's your anxiety practice elements. This is the treatment planner. Remember how we talked about it's anxiety. You have at the beginning, it's the engagement. How do you engage people? Part of it's through the psychoeducation for the child and also the parent or caregiver, monitoring and self-monitoring. And then next, in the middle phase of treatment, you're really going to look at the cognitive pieces of anxiety, relaxation, problem solving, and exposure, okay? And this also gives you the opportunity to list other stressors that are going on, and so you would list those down at the bottom. So psychoeducation. Why do we do psychoeducation with caregivers and children? We need to increase their awareness and understanding on anxiety. It is a key practice element. It is a foundation. You cannot teach somebody how to read if they do not know the ABCs, okay? And so for me, that's what psychoeducation and anxiety is about. It's teaching somebody, if I want them to read, I first need to have them understand and recognize letters and how they work together before I can expect them to read a book. It is a shared understanding of anxiety, and it corrects some of the misunderstanding. It can create clarity and help engage the child and caregiver that's more likely to successfully address anxiety. Okay, what do I mean by that? Sometimes a symptom of anxiety can be a bit, dare I say, layperson, a little bit annoying if you have to live with that symptom on a day-to-day basis. Okay, so pretend I'm bringing my child who has anxiety in to see you as the therapist. My child has refused to go to school. I have CPS calling me and bothering me all the time because my kid's not going to school. I'm in jeopardy of losing my job because my child refuses to go to school. Why can't she just go to school? That's all I need her to do. It's not a big deal. And through psychoed, it's about explaining to the parent that that is part of what's going on with the child, that refusal to go to school, and that we're going to be able to address it. But I need them to understand and not hopefully become less reactive to the school refusal and develop more positive skills and help them understand anxiety and some of the symptoms and also some of the coping skills that will be helpful for them and their child. So really that's what psychoed is about. What I'd ask you guys is to, in the chat box, we're going to have a poll, sorry. How challenging is treating anxiety in children and adolescents? Do you, A, find it very challenging, B, find it somewhat challenging, C, find it, B is find it challenging, C is find it somewhat challenging, and D is that you really don't find treating anxiety in children and adolescents very challenging at all? And I'll just give you a few more seconds before we get the results. And if we could have the results, that would be great. Okay, so for many of us, we find it either challenging or somewhat challenging. Those are the most common answers. And so what we've done here is this is the practice guide for the caregiver psychoed. All we've done is put the steps on there for you. And really, it is discuss strategies. Describe your role of the caregiver, normalize the emotions of anxiety, introduce the alarm analogy, discuss different degrees or stages of anxiety, provide a rationale for treatment, clarify goals, and introduce the idea of monitoring. Okay? That's really great, but what does that look like in clinical practice? Here's an example of information. We're giving information to the caregiver and the child. What is anxiety? Well, there's 3 parts of anxiety: what we feel, what we think, and what we do. That anxiety is normal and can be helpful. It's a built-in alarm system. If I smell smoke in my house, I should feel some type of reaction. You better go check that out, because if I smell smoke in my house and I don't have that reaction, how will I know whether it's a real fire or if my son just burnt his grilled cheese? Okay? Anxiety is normal. It helps motivate us to do something, and sometimes there's real danger. It's important to help them understand and distinguish between real and false alarms. A real alarm, obviously, is real danger. Okay? Exposure is not the treatment of choice for real dangers. False alarms, there is no real danger. To me, this is a lot of the what ifs. What if I'm afraid of dogs and I walk to school and I start not wanting to go to school? First, it usually starts with maybe I have a headache or a stomach ache, and then when I don't have to go to school because I'm not feeling well, that behavior has a tendency to increase. Because I'm afraid, what if there is a dog on the way to school? Okay, so that is a false alarm. What if there isn't a dog on the way to school? So if I'm building my whole whether I go to school or not on my fear of whether I'm going to encounter a dog, that might be a false alarm. I need to be aware if there is a dog and have a plan, but if I live my life what ifing, it's really going to decrease my experiences in the community. And knowing the difference is one of the most helpful things in terms of managing anxiety. False alarm detection. Sometimes alarms are too sensitive, okay? And here's some little bit more information. And we put these slides in here for you in case you wanted to use them as a resource in doing the psychoed with the parent and the child, okay? Then we found this great yellow light picture. Okay, a yellow light. It's important to know a yellow light. A yellow light puts me on alert. Something bad might happen, okay, so I should be on alert, but I don't need to panic, okay? And a red light. Something bad is happening right now and I need to respond. And part of it, anxiety-wise and psychoed, is teaching the parent and the child the 2 differences and how to respond and how to be helpful. So we have a few minutes left, and I'm sorry, the last few slides I kind of pushed through rather quickly because we're running out of time. But if you have any questions, if you could put those in chat, that would be great.
Hi, Julie. Thank you so much for reviewing the different practice elements and how to incorporate this information into dashboards so everybody could get started with their clients. So please take the time now to use that chat box and send to all panelists any questions that you may have. I do want to tell you that all the materials that were mentioned today, both the RCADs, that level of anxiety scale, anything that we mentioned is going to be linked on your PracticeWise website, as well as the PEDS CTAC website, and we will also email you those. The dashboard that already is set up with those 2 measures, the level of anxiety, the slides from today, and the RCADs will be emailed to you as well as posted on both the PracticeWise as well as the PEDS website. So please we have about a minute or so where we can take some additional questions. Julie, if you can move to the next slide while people may be typing in their questions, I can do some housekeeping. So feel free to go ahead and type in any questions that you may have for Julie. In the meantime, I want to point you to these next steps. We did ask that one of the performance indicators that you will be submitting is your depression dashboard from the last quarter. If you were able to do that with a client, please submit that dashboard as soon as possible by September 13th. We will also have a check-in call to start talking about your anxiety case on Friday, September 20th. There'll be a second webinar on anxiety to talk about those other practice elements that Julie mentioned on Tuesday, October 8th, as well as some additional check-in calls. And we are very excited to also be able to invite you to an in-person meeting where we're asking everybody to come on Friday, November 15th, and additional information will be sent out about that in the coming weeks. This is our email. Julie's email is on the bottom left. Feel free to reach out to her directly if there's anything specific there that you want some clarification on, or feel free to reach any one of us. And these are some additional references and resources. Julie, did you want to point out some of these videos?
Yes, I did. For relaxation, again, we're going to speak to that more next webinar. I found a couple very good things on YouTube. And in speaking with clinicians, and the reality is my clinicians at our clinic, we don't have access to YouTube on our work computer. But if you're working with a client and they do have access to YouTube at home, Jelly Belly's a great relaxation meditation. I think it's about 7 minutes, and it really teaches the parent and the child information about how do you relax and how do you do the deep breathing instead of the very shallow, rapid breathing a lot of our children and adolescents do. Mr. Worry and the Giant is taken off all of the books. You know, they have Mrs. Stubborn, Mr. Worry, and this one really focuses on him really worrying about, I think it was about 4 minutes, probably for like pre-K to maybe 2nd or 3rd grade, it'd be appropriate for. Really, he went to a land where there was nothing to worry about, and then he came back to the real world, and he was able to distinguish between things I should worry about and things I don't need to. And then a few mindfulness exercises I thought were really great. They're pretty dynamic. They're cartoon characters. That mindfulness exercise is a cartoon character. It's a part of a series right on YouTube, and it basically helps people stay in the present and not be focused on the what-ifs and the future, but focus on here and now and really pay attention to whether it's eating your lunch, but what's going on about you right now as opposed to worrying and anxiety about future things that may never happen.
Okay, thank you so much, Julie. So those resources are there. We're going to cover a little bit more about that practice element again at the next webinar, but here are some additional resources to get you started. As you can see, the RCADS rating scale and additional information around the RCADS is also at that link, as well as the information we'll be sending to you. It doesn't seem like we got any additional questions. I think we're going to respond to a couple separately. So I just want to thank everybody for participating today. Please feel free to reach out to us, or anyone on the resource team, if you have additional questions or you need help getting started. And thank you for joining us. Take care and have a great day.